Are we going live soon?
Yes, sir.
Okay. All the best.
Thank you, sir. Thank you,
Yeah.
sir.
I'm here only, muted only. No problem.
We are live.
Um, Good evening, everyone. And on behalf of Indian Thyroid Society, I extend my warm welcome to everyone who has joined this FB live program on thyroid awareness. And today we are here to discuss an incredibly important topic which impacts millions of women worldwide, that is thyroid health in women, the agenda for today's session. And to explore more into this and to learn more about this, I would like to welcome three expert panelists on this topic. So first, I take extreme privilege to welcome Dr. Usha Sriram ma'am, consultant endocrinologist, PHS Chennai, and she is a founder for Divas, a non-profit organization for women's health, founded ASIR, past president ISBMR, and a strong advocate of women's health. And next, I take extreme pride in welcoming Dr. Revati Janakiram ma'am, former director IOD Chennai, vice president Foxy 2016, and president TN4, and she's a major driving force for HPV vaccination programs across India. And next, I would like to welcome my dear friend, Dr. Anna Soraya Montero, Assistant Professor, Department of Endocrinology in Goa Medical College. And I am the host for today's session. I'm Dr. Nivedita Kartika, Consultant Endocrinologist from Madurai, and I welcome everyone for today's session.
तस्य भासाय सर्वमिदं विभाति.
We all knew well thyroid disorders affect anyone here, but mostly women are more prone to have thyroid disorders. So, what is the role of hormones in this disparity, ma'am? And why are more women more prevalent to have thyroid dysfunction? And I would like to ask Dr. Usha Sriram, ma'am, to talk about this.
Thank you, Nivedita, and thank you, Thyroid Society, for this very, very important, program, an important initiative that they, put together. Because as we discussed before the beginning of this program, there seems to be a lot of questions, myths, misconceptions about the thyroid. So yes, it's 100% true that thyroid problems are more common in women. Okay. And there are many, many reasons for this. Of course, one is the biology, being a woman, and the hormones that are part of being a woman, especially estrogen. It may also be because of the gender itself, meaning being a woman means, maybe exposure to certain environmental disrupting chemicals, maybe about getting certain, health priorities not, prioritized properly. And also there is, things, the autoimmunity, that most of the thyroid problems are due to thyroid problems, whether it's hypothyroidism or an overactive thyroid, what we call hyperthyroidism, are all usually autoimmune problems. And we all know that women have more autoimmune problems. Examples are like lupus, rheumatoid arthritis, a condition called Sjogren's syndrome. These are all more frequent in women, and they are autoimmune problems. So are most of the thyroid problems. The other things, as Nivedita asked, is it because of the estrogen hormone? There's very good possibility that that's playing a very big role, because there are estrogen receptors in the thyroid gland. Estrogen, excess, like it happens in pregnancy, can change the thyroid hormone circulates in our blood, bound to a protein, and that protein can go up, and the growth of the thyroid can be influenced by estrogen. Estrogen can have an effect on an important hormone from the pituitary gland called the thyroid stimulating hormone. And we all know that there are women go through a certain life cycle, whether it is menstrual cycles or pregnancy or menopause, when there are big changes in the estrogen hormone. So therefore, it can also have an impact on the thyroid gland. So yes, definitely women seem to have, there seems to be a preponderance or some sort of a higher frequency of thyroid problems in women.
Thank you, ma'am. Thank you for explaining it so well. And as we all knew, because thyroid is so common in women, it's most commonly associated with menstrual disturbances. And I would like to ask Dr. to throw more light on it.
Pardon? Okay. So, all of you know that the reproductive hormones are responsible for normal ovulation, menstruation, and reproduction. And all these endocrine organs are interlinked, more so thyroid with the reproductive hormones. Whether it is overactive, as in hyperthyroidism, or underactive, as in hypothyroidism, it can affect menstrual function in so many ways. All sorts of menstrual problems can occur. On one extreme, no menses at all, what we call as amenorrhea, or on the other extreme, heavy menstrual bleeding, what we call as menorrhagia, or in between, irregular menstrual cycle, frequent, infrequent menstrual cycles. All problems can arise as a result of thyroid dysfunction. And another important thing is that suppose a girl has got hyper or hypothyroidism before menarche, there is a possibility that she can have a delayed or early menarche also. More so in the reproductive age group, that is 20, 25 above that, in those women, when they have got menstrual irregularity, you have to think of thyroid problems also. Because in such patients, when there is no other cause for this excessive bleeding or irregular bleeding, thyroid testing will help you to identify the cause. And if the thyroid dysfunction is corrected, she can get rid of the menstrual irregularity and she can become all right also. Thereby, she can avoid unnecessary, even surgical intervention like a curettage, what you call the DNC, or even sometimes hysterectomy. So, in any woman, the menstrual irregularity, if she has got thyroid function, must be tested. Thing is that even before any symptom comes, the irregular menses may be the first symptom she presents with in a thyroid dysfunction. So the moral of the story is, in any woman with menstrual irregularity, thyroid function test is a must. We have to make a diagnosis and treat it in time.
Thank you, ma'am. Thank you for being clear. And now, apart from menstrual disturbances, people with thyroid disorders tend to have other symptoms. So what are all the symptoms which we have to watch for? And also they have some misconceptions about the symptoms and presentations. And Dr. Anna, would you like to burst some of the myths associated with it also?
Thank you, Dr. Nivedita and the Indian Thyroid Society for this opportunity. So in brief, hypothyroid patients tend to have symptoms like fatigue, weight gain, decreased energy levels, menstrual irregularities like Madam Revati Madam mentioned, difficulty in concentrating, dry skin, constipation, while the overactive gland, that is hyperthyroid patients, will have the opposite like weight loss and anxiety and difficulty in sleeping and frequent motions and again irregular menses in the form of less menses rather than prolonged. What major misconception I would like to bring about here is that a lot of hypothyroid symptoms, as I mentioned, like weight gain, fatigue, decreased energy levels, difficulty in concentrating, are very vague and subtle. And in early phases of thyroid disease, while they can be subtle and people may go unnoticed, and it's very important to diagnose yourself. So if you feel that you are experiencing these things, yes, definitely you need to get a thyroid level checked. But if the thyroid is found to be normal, very often the symptoms are still disproportionately attributed to this thyroid level. When you have borderline TSH levels like 5, 6, which don't really explain these symptoms, people still end up believing that it is because of the thyroid and end up being treated unnecessarily. So this is one misconception I would like to bring about to bust. And regarding weight gain, people tend to think that the weight gain in hypothyroidism is really huge, like 10 to 20 kgs, when actually in reality, hypothyroidism contributes just hardly 3 to 5 kgs to the weight gain. So many a times the weight gain is actually in the patient's lifestyle habits. And even once patients are on treatment, one misconception that people tend to think is this weight gain is going to be a persistent problem and that they cannot lose weight even if the thyroid is controlled, which is not true. Even when the thyroid levels are in control, or when they're not in control, you can still lose weight, but maybe with more effort. Definitely, once the thyroid is in control, then the weight is probably not related to the thyroid level. So that is a big misconception that people tend to think. And one more thing is that people tend to believe that once diagnosed with a thyroid problem, your treatment goes on for life, and that there's no other hope. But that's not true. It depends again on the illness, the disease, the condition that you are diagnosed with. Like, yes, if it is a autoimmune hypothyroidism, you might end up requiring treatment for life. If it is an inflammation of the thyroid gland, which we call thyroiditis, it's actually just a transient phase, and you may end up being absolutely normal in about 3 to 6 months. If it is Graves' disease, again, the treatment can be transient, lasting a couple of years. So it depends on the diagnosis, and you need not lose hope.
Thank you, Anna. Thank you so much for the explanation. So now we're moving on to the other areas, that is health and thyroid. So we all know thyroid hormone plays a very role in maintaining the reproductive health, both in men and women, but especially women can have a lot of concerns about their fertility issues and pregnancy complications when they're diagnosed with thyroid disease. And Dr. Usha, ma'am, would you like to talk about this?
Sure. Thank you. I think you brought up a very, very important concern that people have when they have a thyroid problem is, will I be able to get pregnant? Will I be able to carry this pregnancy through term and have a healthy baby? Will this thyroid problem that I have an impact on my child? So these are all very important questions people have. So just want to say that the thyroid hormone is necessary for almost all the cells in our body and all the systems in our body. And we know a pregnancy requires a perfect coordination of all the systems and all the hormones. So therefore, having the thyroid level in the normal range is very, very important. So if it is not, for any reason, either an underactive thyroid, what has been called hypothyroidism, the more frequent one, or a hyperthyroidism or an overactive thyroid, that's also frequent, but not as frequent as hypo. Both of them can have an impact on a woman's ability to get pregnant, meaning first thing we need for pregnancy is egg formation, right? So this egg formation and the egg getting released is what we call ovulation. So if the thyroid levels are not all right, this ovulation can be affected, or the follicle, the what we call folliculogenesis, or the dominant follicle forming and the egg releasing also can be affected. And so it's very important. And then when the thyroid hormone levels are low, there is another hormone that comes from the pituitary called prolactin. This prolactin level goes up. And when prolactin level goes up also, that has a very important, there are consequences in terms of fertility and pregnancy and all of that. So we have to make sure that all these hormones are all maintained in a normal level. So one important message that I want to give people who have been diagnosed with thyroid problem is make sure that before you plan your pregnancy, that the thyroid levels are all normalized. Now, the levels are normal. And also very important that during pregnancy, not to stop the medicine. People have this feeling that I should not be taking any medicine and immediately stop it as soon as they find out they're pregnant. This is not a medicine. This is a replacement of what our body does not have. So very important to keep taking it, because one of the important things that can happen if the levels are not all right is miscarriages and sometimes premature deliveries. Or so very important to keep the levels normal. And then other pregnancy complications like high blood pressure during pregnancy, what we call preeclampsia, and now they're also linked it with gestational diabetes. So for all these reasons, the thyroid levels must be maintained at a perfect level. We like to keep the TSH level below 2.5, especially in the first 12 to 14 weeks. And after that, it can be less than 3, which is still very well controlled TSH level. And then lastly, I want to say a tiny bit of thyroid hormone goes from mother to baby, because the baby's own thyroid gland will start working only around 12 weeks or so. And really, for it to be fully functional, it takes even longer, maybe closer to 18-20 weeks. So the bit that goes from mother to baby is very critical. That's also another reason why we want to keep the thyroid levels super normal. So with keeping all this in mind, must consult the doctor before getting pregnant. And then, as soon as you find out you're pregnant, and if the levels are all kept well, chances are that you will have a healthy pregnancy and your baby will be fine without any complications. And finally, all babies, as soon as they are born, should be tested for thyroid, not just because, as a mother has thyroid problems, but every baby, and especially if the mother has thyroid problem, the baby should be tested for their thyroid levels. And mothers can also have a thyroid problem in the postpartum, after the baby, what we call postpartum thyroiditis. So these are all the implications that thyroid has on fertility and also on pregnancy.
Ma'am, thank you so much for the explanation. So, apart from puberty and pregnancy, that happens in a woman's life cycle, like as often says, menopause is another transition phase that happens in women's lifespan. So, I would like to ask Dr. Revati ma'am how menopause transition interacts with thyroid.
Okay. Say menopause transition, that is perimenopausal age group, is really a crucial period in a woman's life. So at that time, the reproductive hormone, the important hormone, the estrogen is declining. There is lowering of the estrogen hormone in the woman. Now, this causes a lot of menopausal symptoms like sweating, palpitation, and all these things, what we call as hot flushes and all, what we call as vasomotor symptoms. Along with that, they can also have irregular menstrual cycles, mood symptoms, mood disorders, depression, sleep disturbances, loss of libido, and so many other symptoms. Now, the point to note is that all these menopausal symptoms are very similar to symptoms of thyroid disorders also. So in which case, it is very likely that we may miss the diagnosis of the thyroid dysfunction. So this, both the healthcare provider as well as the patient should understand. Now, why should we know about this thyroid dysfunction in this age group? This estrogen has got an impact, that estrogen deficiency has got an impact on bone as well as cardiovascular system, the two important things. It can cause bone loss, causing fractures, that is osteoporosis and fracture, and cardiovascular disease also. Similarly, hyperthyroidism, that is overactive thyroid, also can cause bone loss. So put together, when there is a hyperthyroidism as well as the estrogen deficiency of menopause, there are more chance of osteoporosis and increased risk for fracture too. Similarly, hypothyroidism can increase the risk of cardiovascular disease. So when we can make a diagnosis of thyroid dysfunction and we have got a treatment for that also, why not we make use of that? Why should we do that? Definitely we have to so as to avoid further complications. This is a very, very important thing we have to note about it in perimenopausal age group.
Thank you, ma'am. Thank you so much and, for creating more awareness about this. And Dr. Anna, apart from the reproductive health aspect, and ma'am has also mentioned the points about this mortality and what are the other long-term risks associated with untreated hypothyroidism? We shouldn't just look at the reproductive health aspects also, the metabolic health is also important.
Dr. Usha ma'am and Dr. Revati ma'am have already covered so much on the menstrual part and the fertility part and made my question a lot easier. So as already mentioned in the reproductive age group, the major concern of long-term untreated thyroid disorder is menstrual irregularities and fertility. But in the older age group, as ma'am said, osteoporosis, cardiac disease, besides being triggered by thyroid disease, like it might be unmasked by untreated thyroid disease. Sometimes untreated hypothyroidism, untreated thyrotoxicosis can have ECG changes, which can mimic a cardiac condition, which might not actually be a cardiac condition. So that is something that sometimes people end up being treated unnecessarily when the thyroid is not well controlled. So that also should be an aspect to be borne in mind. People should be screened. Besides that, mental health issues like depression, anxiety, mood swings, so many aspects on our mental health are attributed to uncontrolled thyroid disorders, which are not screened for. Many a times, psychiatric patients are given treatment without screening for this, when they might actually be just suffering from hypothyroidism, and on replacement with hormones, they might actually be much better and not require psychiatric medications. Besides this, older age groups are anyway prone to cognitive decline, but in the presence of thyroid disorders, that is also something that gets aggravated quite a bit. So these are the aspects which we need to look at. And of course, the most catastrophic events like myxedema coma, that is the end stage of an uncontrolled hypothyroid for years, triggered by some infection or some sedative or some small trigger, which has such a high mortality. Even thyroid storm, where people go untreated for so long, hyperactive gland untreated for a long time can come in a thyroid storm and again has high mortality. So these are long-term aspects that really need to be looked at when ignoring any thyroid condition.
Thank you, Dr. Anna. As she has rightly mentioned, though the illness seems to be very non-significant in the initial phase, because it would care about diagnosing and treating thyroid. So now, next question to Dr. Ma'am. Anna has mentioned about the mental health challenges, and apart from that, many women with thyroid illness, they do really have depression because they have thyroid. I know they might be having, and they have to be taking treatment all through the years. So many people end up with depression just because they have thyroid. So would you like to explain and give a clear view of that?
Thank you, Nivedita. I'm not sure if I heard you completely correctly, that people who with a thyroid problem, they get depressed because of that. Is that the question? Okay. We're not able to hear you very well.
Nivedita's audio is a bit problem.
Okay, sure. Is that the question that that people with a thyroid problem, they get depressed because of that? Okay. I'll just expand, on what Dr. Anna has already talked about in terms of mental health. I hope you can hear me, right?
Yes, ma'am.
Yeah. Yes, definitely. Women with
Yes, ma'am.
women with hypothyroidism have a greater chance for being depressed, and usually with treatment their mental health improves if it is exclusively due to the thyroid problem. But we also know that, women generally have more, depression than men, almost 2 times more in the general population also. So when somebody has a thyroid problem and they have a mental health, symptoms, it can be depression, it can be anxiety, it can be just stress, but it can also be due to something else. So one of the things, since this is a public program, and I want to highlight is we should not make the diagnosis ourselves or allow our neighbor or our hairdresser or our family member or someone to tell us, oh, it must be because of menopause. Oh, it must be because you just had a baby. Oh, it must be because this happened to you. No, mental health should be looked at like we look at a knee problem or a headache or chest pain. We must see a proper specialist and find out why we are having depression or anxiety or stress. And only then, and because there are wonderful treatments these days for all these conditions, it may be a thyroid problem. It may not be a thyroid problem. So that has to be diagnosed. And as Madam Revati already mentioned, many symptoms of thyroid, right, are very general. Feeling tired, feeling sleepy, gaining some weight, not feeling motivated, some constipation, dry skin. Every other person will have these symptoms. So it's really important to make a diagnosis, proper diagnosis. Is it a thyroid problem? Is it something else? Or is it simply, mental health issue that can be treated? And also, as Dr. Anna mentioned, cognitive decline. See, things like memory issue, very common in patients, in people who have a thyroid problem. And people also, as they get older, they may have naturally easy forgetfulness. So many times they tell themselves, this must be because of aging, this must be because of menopause, and do not seek to go and find it out. So one very important, piece of advice I'd like to give is always get the right diagnosis done. And thyroid diagnosis has now become so easy and so simple, so inexpensive that you can quickly find out if there is a thyroid problem. And the other thing is, women have certain other things like premenstrual syndrome, PMS, before periods, having some people feel depressed, some people have mood problems, some people feel anxious. And then after having a baby, there is a condition called postpartum blues or postpartum depression. And I just want to say that problem is more, it can be because of a postpartum thyroid issue. So again, only if you test it, you will know. And as Madam Dr. Revati said, during menopause, people can have mood changes and depression. And again, we should not just tell ourselves it must be the menopause or not listen to someone telling us that. So important to go and get a simple test done and make sure it's not your thyroid, because if it is the thyroid, taking treatment can make you so much better. So that's the connection between mental health and the thyroid. Did I answer
Thank
your
you, ma'am.
question?
Yes, ma'am. Exactly.
Okay.
Yes, ma'am.
Sure.
Yes, ma'am. Thank you so much, ma'am. So now, as we have discussed about the symptoms, signs, presentations, and various complications of thyroid disorders, how do we now improve routine thyroid screening in women? And we also pose certain diagnostic and therapeutic challenges. And how do we address that, ma'am? I request Dr. Revati, ma'am, to deal with this.
Well, routine screening for thyroid is a must. Nowadays, during pregnancy, as Dr. Usha Sriram told, almost all pregnant women get their thyroid screening done during pregnancy. But still, as I told, in the menopausal age group, perimenopausal age group, because of the overlapping of symptoms and negligence, they are not getting the screening done. But as such, Indian Menopause Society recommendation, the guidelines strongly recommend that women should get the thyroid tested every 5 years after the age of 35 and every 2 years after the age of 60. Or if they have got any symptom, immediately they have to get the test done. So it is always good to get this testing done during this age group like this. Okay. And another thing is that how to improve the screening techniques or awareness among the patients. Now, most important thing is like as we are conducting today, the awareness program on thyroid and women's health, we should conduct more and more awareness programs for the public. I always feel that our focus on conducting the seminars or webinars, we should show equal importance to the public awareness as we do for the medical CMEs also, because they are the target population. So they must be aware of the signs and symptoms of hyper as well as hypothyroidism. And they should also be aware that what is the impact of the family history of thyroid on getting the thyroid problem in their own. Okay, so all these things they should know. And also that in elderly, as I told you earlier, how to differentiate between this or how to make a diagnosis of the thyroid dysfunction in spite of the symptoms they have got, especially the healthcare providers should know about it. And the challenges, if you I think with all these things, creating awareness, definitely almost now 50% awareness has been created so far. And I think by creating more and more awareness, we can make subject everyone go for screening. And as you said, there are definitely some diagnostic challenges as well as in treatment also. Diagnostic in the sense, first and foremost, is in the elderly, the menopausal symptoms overlap the symptoms of thyroid. So the diagnosis of thyroid dysfunction may be missed. So which what the eyes cannot see, the mind, what the mind does not do, the eyes cannot see. So only if you think of it, you will just make a diagnosis and treat that also. And second thing is that the women I tell this that women, when they find some falling hair or thinning of the hair or some skin dryness, they just get the medicine over the counter. Some medicine they want to get because they want to get relief of the symptoms. Many times that may be containing some substance like biotin, which may interfere with the immunoassay testing of the TSH in the laboratory. So number one is that they should not go for over-the-counter medication. That is number one. Second thing is that if at all they are taking any medicine, they have to inform the consulting doctor also, because if so, they will stop the drug for 2 to 3 days and then they will do the testing. So these are all the small things which in the diagnosis they have to take care of. And if the therapeutic thing is concerned, you know one thing, the upper limit of the TSH slowly increases with the age. Around the age of 50 to 60, the upper limit may be 4. Around the age of 70 to 80, upper limit may be 5.9. And in the subclinical thyroidism, the upper limit may be 10. So when to give treatment? Because especially in the elderly, as I told you, you should not overtreat, you should not undertreat also. Because if you overtreat, you may cause other complications like osteoporosis and other things. Okay, so you should know how to give the treatment to maintain the TSH within the normal range. So this is mainly for the healthcare providers. Another thing about the women is that many a times what happens, I have seen my own patients that I just refer them to an endocrinologist, they are prescribed thyroid. Okay, that's all. And they totally disappear from the scene. And they just continue on their own for quite a long time, or they just discontinue on their own also. This is a very, very bad habit. They have to go for regular follow-up and they have to get the advice from the consultant, and then only they have to either stop, continue, or whatever it is. Okay, whatever advice that is given by the doctor, they have to follow it up. This is a therapeutic challenge when we are treating the patient with thyroid. So all these things we healthcare providers should take into consideration. Thank you. Niveda? I'm
Thank
happy
you, ma'am.
that
Thank
we
you so
have
much. So
started
routine.
this.
Thank you, ma'am. So thank you for that beautiful explanation, like to create more awareness and to improve screening. So it's very vital to address the thyroid challenges in women. And now to Dr. Anna. Most of the patients take thyroid medicines regularly, but still they come with uncontrolled TSH most of the times. And what are the extra precautionary measures which they have to take while they are on treatment with thyroid medications?
Thank you, Nivedita. So, for hypothyroidism in particular, uh, patients, as ma'am, Dr. Revati madam said, they are prescribed, then they forget to follow up. They think that that's the end of the story, and they just continue being on the same dose, irrespective of what their weight has changed and when's the last time they actually went and checked whether that was the correct dose for them or whether they monitored. So I think patients should be made aware that regular follow-ups are a must, irrespective of what the TSH levels are, and some certain basics of thyroid medication, like for hypothyroidism, whatever brand of levothyroxine. Once you are on a particular brand, you should stick to that brand to avoid constantly changing unless it's available. Then once you change the brand, to try to stick to that particular brand, especially in pregnancy, especially for younger age groups where the bioavailability might change from brand to brand. So that is something to change to really emphasize on. Regarding keeping a 1 hour gap between your thyroid medication and your breakfast, then to keep a 4 hour gap between thyroid medication and other interfering drugs like calcium, iron, especially in pregnancy and reproductive age group. That's something that is very basic and yet often not emphasized. And also for them to always try to keep a record of their weights along with the TSH value so that you know that, okay, at this particular weight, you were maintaining well with this particular dose. So if your weight changes, you might need a dose adjustment based on your weight. These are basic things which tend to not get emphasized. And the thyroid bottle also, that it needs to be kept away from sunlight, needs to be capped very tightly and not just loose tablets. Very often, pharmaceuticals will just dispense loose tablets, loose levothyroxine tablets. And the patients are taking them unaware that the tablets might actually be spoiled. And yeah, I think that's about it. Maybe.
Yes, we lost the signal. And thank you so much. Like as you rightly mentioned, so taking the medicine in an empty stomach and leaving a spacing for at least 1 hour before they even have any drink, even coffee or tea. Most of the patients take the medicine with coffee or tea. And so this is something which has to be highlighted. And any other medicines, we have to leave a gap for 4 hours. And thank you so much for highlighting. And now we're at the end of the session. And any questions from the audiences, like we are ready to take.
Are they putting it in the chat box?
The tech team, do we have any questions?
Yes, ma'am. Just checking. No, ma'am. There are no questions as of now.
And can we give a take-home message from each of us, like what a highlight?
I'll start.
Start with Dr. Usha, ma'am.
Yeah, sure. Thank you, Nivedita. And just want to tell people who are listening that thyroid problems are common, easy to diagnose, very easy to treat, nothing to fear. And all these names, Hashimoto's and Graves and all that, are just names of people who discovered these conditions. Nothing to worry about, because people come to me and say, I have Hashimoto's. It doesn't mean anything. So it's just a person who discovered it. So don't worry about anything. We have fantastic now medicines, whether it is underactive or overactive, simple to diagnose. And as Dr. Anna said, if you follow all the simple instructions of how to take the medicine, how often to take the follow-up testing, and keep seeing the doctor at least once a year, right? That's not too often. I think you can really, I'm just saying, be in charge of this whole thyroid issue. And to answer Nivedita's earlier thing, there is no need to get overwhelmed or stressed by the thyroid issue. It's something that we have, as specialists, we have all kinds of wonderful ways of taking care of you.
Good. And as such, the diabetes, thyroid, and all this endocrinological problem, women, generally all have the fear that, oh, this is a disease for which lifetime I have to take some medicines. There is no relief at all. So that is an idea that you have to get rid of it. As Dr. Usha Sriram rightly pointed out, it is not a disease, it is a deficiency which you are replacing and you'll be all right. So that sort of an attitude you should develop. That is number one thing. A second thing, as I told you, routinely you get this screening for TSH done after 35 years, every 5 years, and after 60, every 2 years. That is a must. And of course, during pregnancy, you get it done. And especially elderly, perimenopause and postmenopausal women. See, nowadays, women live for a longer time. 1/3 of life we live after menopause. So we should have a fit life. Okay, that is a quality of life is much more important, for which we should know what are all the causes for our problems we are having. And we doctors are there to guide you properly. So you approach us and let us know your problems, and you get a remedy for that. And easily remedy is available for thyroid dysfunction. So definitely you can take that and lead a quality life. That is much more important. Thank you.
Okay, ma'am. Thank you.
Usha ma'am and Revati ma'am have covered things very nicely, but I would like to re-emphasize the last part, that basically, while it is very important to be aware of thyroid symptoms and screen yourself regularly, there is nothing to be afraid of. If you are diagnosed with a thyroid disease, it is not life-changing, it's easily manageable, and you are as good as anybody else. So there's nothing to worry about. Be aware, screen yourself, but do not fear the results. That's my message.
Thank you. Thank you so much, everyone, for the wonderful discussion we had today, and hope everyone might have benefited with that. So now we are coming to the end of the session. And as all panelists have rightly mentioned, so it's a very cornerstone for overall women's health. So we have to improve awareness, and we have to address the unique challenges that women face with thyroid illness, because that is the main purpose of this discussion, thyroid health in women. And so by then we can empower ourselves and them to have a better future. And with this, I would like to thank all the panelists and all the attendees who had joined the session. Thank you very much once again. Thank you.
Thank you. Thank you so much. Nice to meet you all today.
Same here.
We can